For the nose, the patient did not have colds, no bruising. For the chest, there was a bruise at the left shoulder, also bruising and tenderness at the left rib cage. There's also a red to dark discoloration and tenderness at the area of the T7 left rib. The heart was not assessed. For the abdomen, there were no bruises. For the extremities, there was a bruise at the left buttock, and there were no cyanosis noted on the extremities. For the neuro exam, the patient had a GCS score of 15. She was awake and oriented to time, place, and person. For the cerebellars, she was negative for dysmetria. We attempted to test for dysdiadochokinesia, and we also attempted the heel-to-shin test, but they could not be tested because the patient said that the stiffness in her arms and on her legs made it difficult to perform this test. The patient also refused the Romberg test, claiming that she was scared that she will become dizzy because of it. Yung word na ginagamit po niya parati is baka malula daw po siya. For the cranial nerves, cranial nerve 1 was not assessed. Cranial nerve 2 was also not assessed, but the patient reported blurred vision, which is possibly age-related, and she also uses reading glasses. For cranial nerves 3, 4, and 6, there's no nystagmus on horizontal gaze. For the visual field test, the patient was unable to follow the examiner's finger for the upper visual fields, and the patient moves her head in order to see the examiner's finger. Cranial nerve 5 was not assessed. Cranial nerve 7 was intact with symmetrical smile and equal raising of eyebrows. Cranial nerve 8, there was decreased gross hearing, which is probably age-related. For cranial nerve 9 and 10, there is intact swallowing and no hoarseness of voice. Cranial nerve 11 could not be assessed due to pain, and cranial nerve 12 was not assessed. The motor function was not assessed, but there is limited range of motion. For the upper extremities, I believe it could be at least 3/5 in muscle grading because I was able to ask the patient to raise her arms po to assess if there was any drifting. For sensory, it was unremarkable, aside from with the exception of the pain that the patient was complaining of. So for the salient features of the patient, subjectively, hindi ko po makita. So subjectively, the patient had loss of consciousness with dizziness, associated pain at the various parts of the left side of the body. There's chronic episodic transient vertigo, tingling sensation from neck to arm provoked randomly by neck movement, limited range of motion of the neck, shoulder, hips, and knees, back pain at the thoracic area. There's also constipation, urinary incontinence, arthritis, Alzheimer's disease, and hypertension as reported. And objectively, the patient had a GCS score of 15, a BP of 100/80, heart rate of 80, respiratory rate of 20, and temperature of 36.9 degrees. The patient was awake, oriented to time, place, and person. Negative for dysmetria, no nystagmus on horizontal gaze. Patient was unable to track for upper visual fields, and for the motor had limited range of motion. So in approaching a patient that presents with dizziness or vertigo, there are many possible diagnoses. There could be benign paroxysmal positional vertigo, orthostatic hypotension, Meniere disease, vestibular migraine, panic attack, or psychiatric condition, viral trauma from medications, vestibular neuritis, or a stroke or transient ischemic attack. Now, how do we try to narrow down these differential diagnosis? There are many ways we can look at the timing. Is it episodic? Is it continuous? Is it triggered or spontaneous? Presented here is a table that classifies dizziness on duration. So those that last for seconds are usually yung BPPV and or static hypotension. Those that last for minutes could be transient ischemic attack of posterior circulation or migraine. Those that last for hours can be vestibular migraine or years. Now, the table here below is the complaint of the patient. I divided them according to yung complaint niya about the chronic recurrent vertigo and her latest complaint that brought her to the RHU. For the patient's chronic recurrent vertigo, it was provoked by head movements or position. It was transient and sometimes associated with tinnitus, transient hearing loss, headache, and nausea and vomiting. And for the latest complaint, it was sudden, intermediate with loss of consciousness and with visual neurologic deficit. So we can also try to classify vertigo according to their possible origin, which could be peripheral or central. So peripheral and central, we can differentiate them according to onset, intensity, duration, direction of nystagmus, effect of head position, associated neurologic findings, and associated auditory findings. For the patient, chronic vertigo, they are usually sudden and intermittent, and also head position induces the vertigo. Whereas for the acute complaint, it was also sudden, and there was a little change but worsened with head position change. And there was also an associated neurologic findings. So, sorry po, hindi ko po ma-hide yung toolbar. Pero for the patient's chronic recurrent vertigo, it is probably peripheral and probably BPPV. And for the latest complaint, it is central and probably posterior circulation ischemia. Okay, so this is my initial assessment for the patient on my first SOET. My assessment was to consider benign paroxysmal positional vertigo. However, as you can see, it is very short and incomplete. In retrospect, I can see that it is not a good primary working impression because I only focused on one disease entity out of all that was present in my patient. So we can tell from the history NP alone that aside from the vertigo, the patient also suffered physical injuries, probably from a fall that happened due to her sudden loss of consciousness. And she also mentioned taking maintenance medications. So, meron pa po siyang ibang mga sakit na I should have considered. And any ongoing disease must be included in the primary working impression because it will affect how the patient will be managed as a whole. Now, from my initial assessment, I also ordered this. I also had this plan. I referred the patient to NNH and MC and ordered the following for diagnostic, therapeutics, and monitoring. However, kasi nga po, incomplete yung nilagay ko dun sa assessment, parang naging given na po na incomplete din po yung plan. So, for the following problems for the patient, parang yung physical injuries lang yung na-address ko for the plan and hindi po enough yung mga orders ko for the loss of consciousness, the vertigo, and diagnostics for possible physical injuries. And I was not able to order anything for the to confirm the type of arthritis that the patient has, if she really does have hypertension, and also to confirm her Alzheimer's disease. So, um, I revised my assessment based on the salient features. This is what I should have done in retrospect. So, common po sa elderly patients na mag-present with many diseases. It can be acute on chronic or chronic diseases na magkakasama, and they can also have a lot of comorbidities. A good way to approach such a patient would be to go through it problem based. So listed here are the problems that I think should be addressed in the patient. The patient has a probable CVD infarct, probable BPPV, multiple physical injuries that are probably secondary to fall, possible hypertension, arthritis, and Alzheimer's disease. So um, for each problem, we will have a separate plan so that we will be organized. So this is my revised plan based on the salient features. Ito po yung una kong plan that was incomplete. And this is my revised plan. For the probable CVD infarct, I will refer the patient to a tertiary hospital, admit to stroke ward, order a diet of low fat, low salt with strict aspiration precaution, fluid of uh, plain saline solution, diagnostics of cranial CT, um, 12 lead ECG, urinalysis, CBC, ESR, serum electrolytes, BUN, creatinine, blood glucose, serum lipid profile, CT, and CTT to try to rule in or rule out my differential diagnosis on where the loss of consciousness may have come from, and also to see if there can be any other cause for the dizziness or vertigo of the patient. And for monitoring, dahil probable CVD infarct, we should monitor the vital signs and have neuro checks P1 for 24 hours. I will also order monitoring of input and output and to watch out for deterioration in vital signs and neurologic deficits, such as spatial drooping, speech slurring, dizziness, loss of consciousness, and others. For the probable BPPV, I tried to I tried to have the Dix-Hallpike maneuver performed on the patient. The Dix-Hallpike maneuver po is used in diagnosing benign paroxysmal positional vertigo. However, the patient could not tolerate it kasi nahihilo daw po siya. So, for this, we can recommend that the patient go for cranial MRI. However, this is quite expensive po. Also, the patient is high risk for falls, so we have to do appropriate precautions such as keeping the bed rail up and the bed level low, and advise to watch out the patient's status and instruct them to arrange the patient's things where they are easily within the reach of the patient. And because the patient cannot go to the toilet without assistance from another person, I will order insertion of IFC with consent of the patient. For the multiple physical injuries, I will order paracetamol 500 milligram tab PRN for pain, Q6, because the patient can still tolerate oral feeding, and bed rest, also to limit physical activity. And because the patient probably has bruised or broken ribs, we have to watch out for worsening of pain at the rib cage and difficulty of breathing. And for the possible hypertension, because we need to confirm po if the patient really does have hypertension, I will order for 24-hour blood pressure monitoring and to refer if elevated BP, more than 120 millimeter mercury SBP and more than 80 millimeter mercury DBP that is observed on two separate occasions. For the arthritis, I can ask the patient for picture of the prescription form from the attending physician, and the same for the Alzheimer's disease. And I can also refer po to the IM Ruma department for co-management. Now, is there a lesion in the patient? Yes, I believe there is a lesion because there is a focal neurologic deficit of the upper visual fields. And where is the lesion? It is probably in the upper motor neuron. Lateralized, it can be unilateral or bilateral, probably at the medial temporal lobe at the myosine. And from the presentation of the patient, it is most probably vascular in origin. For my diagnostics, on the CBC, the patient has microcytic hypochromic anemia. She also has low INR and elevated creatinine and slightly hypokalemic and hyponatremic. Now for the chest X-ray, on the left is the AP view and on the right is the PA view. For the AP view, there's good visualization and good exposure taken with good inspiratory effort. The trachea is midline. We can note scoliosis of the spine here, and there are no visible fractures. We can also appreciate an opaque aortic knob that is probably atherosclerotic, and um, there's also hyperlucency of the lungs. On the right lung, on the right side, we can see that there is widened intercostal spaces, flattened diaphragm, and a flattened claustrogenic angle compared to the left. This could be due to the severe scoliosis of the patient. And we can also see some opacities that can be reticular or reticulonodular at the upper left field and on the basal fields on both sides. For the PA view, there's poor visualization, but we can still see that it was probably taken with um, poor inspiratory effort. Same with the AT view, you can still appreciate the trachea that is midline, the opaque aortic knob. There is no visible or there are no visible fractures, and um, you can still note the scoliosis on the spine here, and still hyperlucency of the lung fields that can signify hyperaeration, but more on the right than on the left. There is still the opacities, the reticular or reticulonodular opacities on the left upper lung field and on the right basal lung fields. Now for the cranial CT of the patient, um, the skull is intact, the midline is straight. We can see here that the basilar artery is hyperdense, also with the um, uh, MC, probably the MCA and posterior cerebral arteries. This could point to an acute bleed, or it could also point to um, atherosclerosis. Now, for the images on the next row, we can appreciate physiological calcification of the pineal gland and the choroid plexus. We can also see that there are enlarged ventricles here, and there is also enlarged sulci, yung mga medyo puti po on the parenchyma. Yan po, parang na-outline po na ganyan. Mas visible po here. You can see again the enlarged sulci on almost all of the slices of the sa may upper part na po ng brain. Medyo mas obvious po on this particular slide. So enlarged ventricles and enlarged sulci are consistent po with the patient's Alzheimer's disease. So my final diagnosis is CVD in part, PCA segment, probably atherothrombotic, to consider benign paroxysmal positional vertigo, multiple physical injuries on the left ear, shoulder, ribs, and buttocks, probably secondary to fall, Alzheimer's disease, anemia, probably secondary to nutritional deficiency, to consider arthritis, probably rheumatoid. But looking back, I think it might not be rheumatoid po pala, because rheumatoid arthritis will usually affect all the smaller joints like the proximal interphalangeal joint, metacarpophalangeal, or um, meta, usually po sa smaller joints po sila. As compared sa patient po whose affectation were neck, the shoulders, hips, and knees. So probably po, it could be osteoarthritis po and not rheumatoid arthritis. Also to consider hypertension and scoliosis. So discussion on posterior circulation ischemia. Now, stroke is a cerebrovascular accident. It is an abrupt onset of our neurologic deficit that is attributable to a focal vascular cause. An ischemic stroke is due to occlusion of a cerebral blood vessel and causes cerebral infarction. So here on the picture, we can see the possible etiologies of a posterior circulation ischemia. It could be from a left ventricular thrombi in the heart, a valve disease, atrial fibrillation, cardiogenic emboli, carotid plaque, arteriogenic emboli. It could be from flow-reducing carotid stenosis, a penetrating artery disease, intracranial atherosclerosis. Stroke within the posterior circulation. Major arteries, the vertebral, basilar, and PCA supply the cerebellum, medulla, the pons, the midbrain, the subthalamus, the thalamus, the hippocampus, and medial, temporal, and occipital lobes. And occlusion of each vessel produces its own distinctive syndrome. Now, occlusion of the posterior cerebral arteries can produce either the P1 or the P2 syndrome. The P1 syndrome usually produces midbrain, subthalamic, and thalamic signs, whereas the P2 syndrome will produce cortical, temporal, and occipital lobe signs. Occlusion of the distal PCA causes infarction of the medial, temporal, and occipital lobes. Contralateral homonymous hemianopia with macula sparing is the usual manifestation, and occasionally only the upper quadrant of the visual field is involved. So the frequency of common presenting signs and symptoms in posterior circulation infarcts, they could present with dizziness or vertigo, dysarthria, nausea or vomiting, loss or alteration of consciousness, limb weakness, ataxia, or nystagmus. In my patient, dizziness or vertigo, along with loss or alteration of consciousness was observed. So here po, we can see the visual pathway. Okay, so any lesion po along the visual pathway can produce the defects that are listed here on the left. So for my patient, she had a visual defect po on the upper visual field, but I was not able to elicit if it was only on one side of the visual field or if it affected the entire upper visual field. However, from her presenting symptoms, I can probably localize the lesion to be at the Mayer's loop at the temporal lobe. It could be unilateral or it could be bilateral. Yun nga po, hindi ko po kasi na-elicit if the whole visual field po is compromised. So, for the algorithm of stroke and TIA management, this was also discussed yesterday, but we can go through it again. So for patients with stroke or TIA, we get the ABCs and the glucose, and we obtain brain imaging. Then we classify either ischemic or hemorrhagic stroke. For the patient with her symptoms and her general data, most likely ischemic stroke. And for this kind of stroke, we consider thrombolysis, thrombectomy, and we establish the cause, which could be atrial fibrillation, carotid disease, or others. We treat according to what the cause is. And after that, we do deep venous thrombosis prophylaxis, physical occupational speech therapy. We evaluate for rehab, discharge planning, and secondary prevention based on the disease. Now, the common cardiovascular diseases of the late adult life are atherosclerotic thrombotic occlusive disease, embolic disease, lacunar stroke, brain hemorrhage that can be of multiple causes, multi-infarct dementia, and Binswanger disease. For my patient, what I considered po was atherosclerotic or embolic disease from her presenting symptoms. So discussion on benign benign paroxysmal positional vertigo. From the name itself, BPPV, benign because it's not life-threatening. Paroxysmal, it comes in sudden brief spells. Positional, it is triggered by certain head positions or movements. And vertigo because it gives false sense of rotational movement. The pathophysiology of BPPV, so the autoconia is normally normally does not they are normally in fixed in the utricle and saccule, but they can migrate into one or more of the fluid-filled semicircular canals. And when this happens, the fluid will move, which will excite the nerve endings in the canal. And the nerves will send a message to the brain that the head is moving, even though it's not. And the information mismatched with the other ear is perceived by the brain as a spinning sensation or vertigo. Now, listed here are some of the recommendations from the CPG of the American Society for Otolaryngology for the management of BPPV. Now, for the diagnosis of posterior and lateral or horizontal semicircular canal BPPV, what we can do is the Dix-Hallpike maneuver, which I attempted to be performed on the patient but could not be performed because the patient complained of dizziness. After diagnosing BPPV, an initial therapy that we can give is the canalith repositioning procedure, or also called the Epley maneuver, but could not be performed with the patient as well because the same complaint of dizziness. For medical therapy, it is not recommended that we use antihistamines or benzodiazepines for patients with benign paroxysmal positional vertigo. And for outcome assessment, clinicians should reassess the patients within 1 month after an initial period of observation or treatment to document resolution or persistence of the symptoms. So while I was studying this case, one clinical question that I explored is adjuncts for pain that could be used for bruised or broken ribs. For my patient po kasi, she was complaining po na mahapdi yung tadyang, and it was tender po kapag natatouch. So, because there is a high probability po na she suffered from a fall, I was highly suspicious po of a bruised or broken rib. Now, a bruised or broken rib po is managed managed on sorry, it is central on pain management po and controlling of the inflammation. For the inflammation, I recommended po an cold compress with an ice pack or an ice bag. And for the pain relief, I ordered po paracetamol. However, the patient did not like po yung cold compress. She refused that po kasi she said na parang napapaso daw po yung feeling. And ang sabi niya, gagamit na lang daw po siya ng salon pass. So, I tried to explore other adjuncts that can be used for pain aside from yung ice or cold compress po. So, this is a research that explored the effectivity of lidocaine skin patch in the treatment of traumatic rib fractures. This was a randomized double-blind study that was conducted on trauma patients with isolated rib fractures. So it was divided into two groups. One group was given lidocaine 5% skin patch with oral analgesic, and the control group was given placebo vehicle patch with oral analgesic. The outcome was the use of lidocaine 5% skin patch in patients with isolated rib fractures, alleviated pain, and shortened the hospital stay, and the lower dose of pain-relieving medication was used. So, for patients who cannot tolerate cold compress, we can perhaps recommend na lang po yung lidocaine skin patch. So, in summary, in coming up with a diagnosis for a patient presenting with dizziness, one can narrow down the differentials by classifying the dizziness by its duration and possible origin. Provocative maneuvers such as the Dix-Hallpike maneuver can help differentiate between central and peripheral etiologies. BPPV, as compared to other causes of vertigo, is intermittent, transient, and is provoked by head position or movement. BPPV is a vertigo of peripheral origin. It is triggered. It only lasts for around a minute, and posterior circulation ischemia, in comparison, can produce vertigo of central origin. It is spontaneous, it can last for many minutes, and has accompanying neurologic deficits. And lastly, for an elderly patient, They can present with many acute and chronic conditions, and each must be addressed and not treated in isolation. And that is all for my case presentation. Thank you for listening.
Thank you, Maureen, for acknowledging that we should treat patients holistically and not just their chief complaint. Okay, so now we have questions from the chat box. We'll run through them. Uh, can you describe how the visual fields were tested?
Um, since this was teleconsult po, I gave instructions po to the barangay health worker po. For the visual field test po, in-instruct ko po yung patient through the barangay health worker po to have one eye covered po with her like kung kunwari po yung right hand to cover her right eye, and then we will test the upper fields po with sorry. Gagamitin po ng examiner yung finger niya and move it on the upper and lower fields, and itetest po kung nakikita po nung patient po yung finger. So, iwiwiggle po nung examiner yung finger niya, for example po, on the upper field, and the patient will say if she can see the finger wiggling or not.
Okay, I'll interrupt you. Can you turn on your camera?
Ay, sorry po.
Okay, imagine that you are giving instructions to us through telemedicine. Because the limitation with your barangay health worker was that everything was by text. Tama?
Yes.
So you have to simplify what's written in Demayer when you instruct somebody by phone or by text if they do not have camera. So it's a limitation with consultations right now. So sige, let's pretend that right now you're giving instructions through a camera through a patient on the other end and you want to test their visual field. How would you do it?
Sorry po, Dok, naging choppy po. Yung kausap ko po, Dok, yung patient po or yung health
Kunwari
worker?
ako ngayon, kunwari ako ngayon yung pasyente. Doktora, kasanunukwat ti aramiden tayo. Kitaim ka no jay panagkitak.
Ay, Dok, okay lang kung magtagalog po ako.
Ay, opo, sige po. Nakikita, sabi daw po ay titingnan nyo kung paano po mag-examine ng paningin.
Okay. So,
Ano pong gagawin natin?
sir, ito pong gagawin po natin. Kunin niyo po yung right hand niyo po. Right hand. Tapos, takpan niyo po yung right na mata niyo po. Okay. Tingin lang po kayo dito sa ilong ko. Tapos, itong daliri ko po, imumove ko po siya sa different na areas. Pag nakikita niyo po yung gumagalaw na daliri, sabihin niyo po na nakikita niyo po. So, medyo ano po yung angle. Nakikita niyo po ba? Nakikita niyo po?
Hindi pa po.
Nakikita niyo
Nakikita
na
ko
po?
na po.
Okay po.
Nakikita ko na po.
Ito po, nakikita niyo po?
Hindi po.
Nakikita niyo po?
Opo, natatakpan ng pangalan nyo pero opo.
Oh, okay, so ganun po yung gagawin, Doc. On both eyes po. Tapos,
Okay. Before the pandemic, nakapunta ka na ba sa OPD? Nung first year kayo, nakapunta ba kayong OPD award? Yes, okay. So, compare and contrast how you did it live in front of a patient and now that you're doing it like this.
Definitely po mas madali po nung face-to-face kasi
Okay.
i-instruct po directly yung patient. And yun nga
Okay.
po, as po kanina, may problem po sa camera angle kasi baka po dahil lang sa angle ng camera kaya hindi po nakikita ng patient and not from
Okay.
visual field defect po talaga.
Tapos, Kasama din sa instructions ngayon na kapag nagkonsulta kayo by telemed, puwede niyo po bang i-full screen yung inyong screen, gano'n?
Oh,
Or, yung kasing visual field test nga, kung magkokonsulta kayo by a small device, di yung small device, sakto lang siya sa gitna ng visual field. Yung ulo mo na maliit, kahit ikaw sa visual field mo nasa gilid, dahil yung patient kaharap mo at yung small device nasa harap, sakto sa gitna ng kanyang sharpest field of view, yung nakikita niya. So you might think that the patient has a full visual field, but actually, your small device is exactly where the vision is sharpest, but you cannot see the edges anymore. So, I'm just acknowledging na lahat tayo nangangapa ngayon at magkonsulta, but these are issues you will be facing if you do it by telemed instead of face-to-face. Okay, how do you what do you mean that the patient has an upper field visual field deficit?
nung tinatest ko po sa barangay health worker, what was elicited po was, kapag sa upper field daw po yung tinetest, tumitingala daw po yung patient, gumagaling daw po siya. Kasi hindi daw po niya makita.
Okay, tama. Okay. Uh, if the patient has to look up to see things up, is it a problem because she has a visual field defect up there? Or because her EOMs cannot look up, which is why she has to look up there? Or is there a way for you to test that the reason why she needs to chin up is because her EOMs don't move and not because she has no visual field defect up there?
Nag, nagsa-choppy po yung sound ko doon.
Ay, sorry. Okay, round 2. Sabi mo na tama, ako yung birth, di ba? So, kapag magtitingin yung pasyente pataas, ititingala niya yung ulo niya. Okay. So, ang iyong assessment doon ay meron siyang visual field defect sa taas at kailangan niyang itaas yung ulo niya para makita niya doon sa intact visual field niya sa baba. Yun ang assessment mo.
Yes po,
What
Dok.
if the patient can actually see everything but their EOMs do not go up? And so she'll have to chin up because her eyes only go up there. So yung buong
Ah,
ulo niya isasama niya.
yes po.
How will you
Possible po.
test that different? How will you test that so you'll be sure, okay, it's an EOM problem and not a visual field problem?
Um, I can probably test for with visual threat po, Dok. Para po
Okay,
makita kung
tama.
visual field problem kita.
Okay, tama. But you cannot do visual threat on a small screen, diba? You have to be beside the patient. Okay, next. What do you think is causing the tingling in her arms on neck movement and the stinging pains on that strip of skin on her left trunk?
Sa tingling in her arms on neck movement po, I considered po na baka may narrowing na po dun sa kanyang um, carotid, internal carotid artery po, which could be um, either that po or there could be nerve compression po that is causing that tingling on her arms. That's why I ordered po for head and neck cranial CT, but I was not able to appreciate any kind of compression po. Now for the stinging pain on a strip on her left trunk, um, what I think caused this po is a bruised or possibly fractured po yung particular rib po sa may T7. That's why it is much more painful compared to the rest of her body that also had bruises po.
Okay, may follow-up question tayo. How can you verify or test the tingling sensation in the arm. Pero sige, how will you verify or test the tingling sensation in arm in a live patient? Face to face, paano mo gagawin?
Ita-try ko
Ideal
po,
tayo kunwari. Sige.
ta-try ko pong i i-elicit po ulit yung tingling po by having the patient move her neck on various positions po and see what particular position po will produce the tingling. Papa-report ko po sa kanya kung nakikil niya na nakukuryente ba or hindi po.
Okay, so bubuuin mo yung alphabet na PPQRST. Yung
Opo.
isang P doon provoking, yung isa pang P palliating. So may direksyon ng ulo niya na kapag ikas jay na, nagkuritang jay iba na. Ah, paano yun? Kung ginalaw niya ng ganun, okay dok, nagkuryente siya hanggang hiniliit ko. What would be your assessment of that?
Kahin liliit lang po, Dok.
Kunwari, gumanyan siya, tapos, ay, dok, hanggang gano'n.
Possibly nako-compress po sa may brachial plexus po, dun sa may root po ng C, 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 from that particular nerve po, yung root po niya, baka po nako-compress po dun sa pag nag-flex po yung neck.
Okay. Meron ka kasing slide malapit sa dulo. Lidocaine patch for rib pain. Tama? Okay. In your vast readings, if a patient complains of pain, which is, if a patient complains of body pain, like this Lola, what can cause pains in this Lola? Or at least what are the etiologies you were imagining for the patient's rib pain?
I was considering po na pain from bruised rib po or from yung ang inisip ko po kasi is nahulog po siya dahil po sa pagkahilo dun sa loss of consciousness niya and most probably tumama po yung left side ng body niya specifically dun sa may left rib po. And I think that is what was causing po the pain in the Lola. And to address that po, I will follow po yung recommendations po for possible broken ribs or bruised ribs na pain relief po and controlling po of the inflammation.
Okay, so there are different kinds of analgesics, ano? There's paracetamol, there's celecoxib, naproxen, there's lidocaine
The
patch,
neck
pregabalin,
extensors.
gabapentin,
Okay, so
tramadol, morphine.
aside
Do they
from
all work
the
in the same way?
the
Or do they treat a specific kind of pain better than others?
From what I've read po, paracetamol, for example, is and does not have anti-inflammatory effects. Whereas yung NSAIDs po are non-inflammatory and can also provide pain relief. However, I read po on one journal na they do not usually give po NSAIDs on 2 days po from suspected rib fracture because it might interfere daw po with healing. That's why ang in-order ko po muna to be on the safer side is yung paracetamol since nasa OPD po yung patient. Yun po yung cheapest na possible ko pong pwedeng ibigay sa kanya for pain relief po.
Okay, so there are other reasons for pain. There's tissue pain, it's somatic. There's neuropathic pain, where the nervous system is the one injured and is producing pain. Or they can mix up all together. So in going back to your patient now, do you think she has any of these or a combination of these?
I think she had somatic pain po and I believe more of the somatic po yung pain po ng patient.
Okay, we'll get back to that later. Sige. Are enlarged ventricles specific to Alzheimer disease? Or are enlarged ventricles part of aging, but Alzheimer disease is pathologic aging?
Um, I was not able to read po if they are specific to Alzheimer's disease, but I was
Okay. Kasi dun sa presentation mo, sinabi mo, the patient has enlarged ventricles on CT scan, which is consistent with Alzheimer disease. May line kang ganon. So this is the root of that question. Does it mean that if you have an old patient with large ventricles, they have Alzheimer's? Or large ventricles is part of being old, but Alzheimer's is pathologic getting old?
I think it's more of the pathologic aging po yung Alzheimer's. Kasi ang nangyayari po with Alzheimer's is nag-shrink po yung it's the Alzheimer's po that is causing the shrinking of the brain. Kaya po nag-enlarge po yung ventricles po and soul size.
Okay. Before we'd like to invite spoken questions from the audience if there are any. Before we give the answer key. Para si PC, no, pero buhay. Promise, buhay silang lahat as of right now.
Maureen, can I see your final diagnosis?
Yes po, Doc. Morning po, Doc. Wait lang po. Ito po, Doc.
CVD infarct. Okay. Wait lang, may nag... CVD infarct, multiple physical injuries, secondary to fall. The Alzheimer's disease was proven.
It was diagnosed daw po by a family friend who's a doctor to e-consult din po, Doc.
So is the patient on any meds for that?
Yes po, Doc. The patient is on donepezil po and multivitamins, calcium
So
and vitamin
already
D.
known AD. Okay. Wait lang. Parang sa layo ng PCA sa BPPV. But the patient's chief complaint was
Dizziness po, Doc.
dizziness. She's old. She also has neck pain, right?
Ano po, Doc? Sorry po.
Does she have neck pain?
Neck pain. Wala po, Doc.
Sorry, I came in late eh. Hindi kita nasimulan. Sige, yung answer key, ibigay na ni Dr. Manalo. Sige.
Saan na ako? Okay, game. Answer key. So this patient did consult by telemed. This patient did have another family friend doctor who started donepezil previously. Okay. What was not asked was how this patient walks. Pero kasi at the time of consultation ay nahihilo siya. So mahirap nga naman palakarin. So mahirap magpalakad ng nahihilo. Okay, next. So the patient was found on the floor. So we have many different hypotheses for being found on the floor. So the one you discussed most was, wait lang nga.
Ay, sorry. Ay, sorry, parang on pala mic namin pareho. Sorry.
Okay, game. So there are different reasons of falling to the floor. There's syncope. There's a stroke na tama naman. There's heart attack, there's BPPV, there's all of the sorry, dizziness pala yung sinabi ko. There are different reasons to be dizzy. You can have a heart attack, you'll faint, you'll have a stroke, you lose consciousness. You feel dizzy, you cannot fall, or you have a problem and you don't know how to say it, you just say you're dizzy. So those are the 4 general categories of dizziness. On the other hand, old people also faint. So there are also different reasons to faint. You can have a heart attack, or you can have weak vasculature in your legs and you'll faint. Uh, you can have a central problem, which is why you will faint. Okay. So there are, besides Alzheimer's, you can also, uh, you could have also asked if she had difficulty walking beforehand, or if she was rigid beforehand, or if she had tremors beforehand. Because old people can have different neurodegenerative diseases. The most popular two are Alzheimer and Parkinson's. One's forgetfulness, one's rigidity. You can have other neurodegenerative lesions like progressive supranuclear palsy. They cannot look up because their brainstem is degrading. So part of the syndrome is they cannot look up. Their EOMs can look this and this, can look down. But if they will look up, they will have to tilt their head because it's stuck straight. But the EOMs are intact. Also, these patients with multiple system atrophy, it's the other old name. There are 3 versions, the autonomic, the cerebellar, and the Parkinsonian. So what was not asked was what was the patient's BP lying down? What was the patient's BP sitting up? What was the patient's BP standing up? Which are difficult to do in this patient because at the time of consultation, she could not turn her head at all kasi at the time acutely dizzy siya. So valid naman na mahirap siyang i-text. Next, there are a series of questions here on why uh, on what the stinging pains are. So, uh, I am listening to the way you answer, and it's you are thinking of a vascular lesion, uh, which is not false. But you should also consider na ang ugat sa Pilipino ay hindi blood vessel lang. Ang ugat sa Pilipino ay pati nerves. So, pwedeng yung mismong nerves nga ang naipit. Pag gumanyan siya, magre-radiculopathy siya papunta doon. Pag gumanon, papunta sa kabila. Tapos may question nga dito sa chat box. So scoliotic si Lola. Her spine is kinked. Ganyan palang itsura niya. So there was a drawing by the Teki Bantay of which strip in her body hurts. So you could have flipped that picture over and matched it up with her x-ray. The kink in her scoliosis matches the sad faces in her drawing. So pwede nga naman na nung napaupo siya, nag-radiculopathy siya dun sa naipit na nerve nung hinimatay siya. Now, you will give analgesics for the different bruises all over her body. Which is why there was the question earlier, how many kinds of pain are there? There's somatic, there's neuropathic, there's mixed. And you can have a combination of those in your patient. So, yung kanyang sakit sa ulo o yung mga pasa niya, somatic. Yung mga radicular neuropathic pains niya, neuropathy. So, yung lidocaine patch might not work well for the somatic pains, but they will work for the neuropathic pains. On the other hand, yung patch na dinescribe mo ay matagal na naming hinahanap kasi natanggal sa market sa Pilipinas. So the replacements of many seniors for neuropathic pains is mental patch, salon patch. They will feel the warmth, and the warmth will distract them feeling the warmth will distract them from feeling the neuropathic pain. So it's a subjective relief, which we will accept because it's just the best we have right now if they don't like the side effects of the other neuropathic pain drugs. Okay, are there any other inputs from our live and online audience before we go to our next patient?
Hi, sorry, I came in late. I didn't start on time. But adding to what Dr. Manalo said, dizziness, it's very complex. So it can be vascular, it can be due to visual complaints, it can be metabolic, gutom, dehydrated, no? It can also be problems due to problems in the cerebellar system. It can also be due to problems in the somatosensory system, balance, proprioception, okay? And this is an elderly patient known AD, Alzheimer's disease. So there's actually a lot of differentials, and there's actually a lot of maneuvers and tests that we have to do, just to be able to localize where her dizziness is. So Dr. Manalo mentioned already multi-system atrophy. Okay, you also mentioned Parkinson disease and progressive supranuclear palsy. If I may add, do you watch Hospital Playlist? No, you don't. There's an episode there where one of the patients developed normal pressure hydrocephalus. So she also presented with behavioral changes, memory problems, and gait instability. Then she fell. Okay, so actually gait instability in the old people, there are a lot of differentials. Okay, BPPV kasi nag-resolve. No, you were not able to do the EPLI to diagnose it, pero there are a lot of differentials. So, may question kasi dito sa chat box about hydrocephalus in are enlarged ventricles specific to Alzheimer's disease? Or are enlarged ventricles part of aging but Alzheimer's disease is pathologic? Could you care to answer that, Maureen?
So po yung enlarged ventricles po, hindi po siya specific to Alzheimer's disease. Pwede pong due din po siya to like may nag-accumulate po na fluid po dun sa ventricles. And yung enlarged ventricles, part of aging. Dun sa question po on, are enlarged ventricles part of aging? Yung sabi ko po dun sa, ang nasabi ko po kay Doc Manalo po kanina is, it could be, I think yung sa Alzheimer's disease po is pathologic kasi nagkaka-atrophy. Yes, nagkaka-atrophy po dun sa brain na nag-cause ng mag-shine brain kaya po na-end yung ventricles po, Doc.
Okay, so there's brain atrophy, there's less of your brain matter. So relative to the ventricles, the ventricles look big because your brain shrinks, okay? But that's what you call ex vacuo hydrocephalus. We see it in Alzheimer's disease. But there's another kind of hydrocephalus in the elderly that also presents similarly to Alzheimer's disease, and that's normal pressure hydrocephalus. Actually, I think Dr. Yaguno would have more experience with normal pressure hydrocephalus, sir. Yeah. So you might, but we don't have, we were not able, we cannot do, we're limited in the maneuvers that we can do, not to test, to further examine our patient and be more precise with our diagnosis. That's all. Thanks.
Thank you po, Doc.
Dr. Yaguno, I think has something to say. Hang on.
There is what we call hydrocephalus ex vacuo. So the ventricle appear large because there's a lot of brain atrophy. So we've seen a lot of patients like that, and for some reason there's no evidence of dementia. Normal pressure hydrocephalus, I don't see any patients with dementia either. So, but we treat this patient because they develop some visual problems thereafter. We treat them with lumbar punctures repeatedly to bring down uh, the pressure for some reason, or we shunt them. So as far as Alzheimer's, sometimes you see dilated ventricles, sometimes you don't see any evidence of dilatation of the ventricles. So that's what my experience shows. And anyway, I congratulate Maureen. It's very extensive discussion that she did. She researched a lot of things, including pain management, dizziness, and all these things. I was late, so I didn't get the real history, whether there was a fall.
There was a fall.
Yes,
The
he
chief
was
complaint was she was found on the floor.
okay. Could have been seizures there. Is there any evidence of urinary incontinence? Did she bite her tongue? Something like that, which should be part of the history and presentation of the case. But anyway, so I was late, so I don't have any further thing to say. Maybe we can move on to the next case. Thank you, Maureen. Very good. Well researched.
Marge? Thank you, sir. Marge?
Yes, Doc. Good morning po.
Okay,
Hello.
they have inputs regarding her rheuma and her scolio and her other issues.
Marine just referred them to ortho. Joke lang.
Kasi yes.
Marine, I'm an ortho. But what I would like to commend is you recognizing this very extensive list of problem and then zeroing in on what's essential. That's very important. But having said that, just to remind everyone not to underestimate pain as a chief complaint, because I think that's one complaint or symptom that is usually underestimated and undertreated, especially now among elderlies. We often say, matanda na kasi, nag-edad na, so normal na yan. So we shouldn't. We should have to evaluate what's the source for us to be able to treat it adequately. Okay, katulad ng sinabi ni Dr. Manalo, there are different sources of pain, and when you give them, you're providing synergistic effect. So that's really important. As to the rib pain, actually, personally, I do not have any experience with that lidocaine patch. So usually what we have are yung mga cryotherapy sprays namin, we have yung topical gels, and then yung different WHO analgesic ladder na mga drugs. And you have to really explain to the patient na yung type of pain with rib fracture is usually deep, nagging, and usually longer yung course, because if you think about it, very little yung amount of soft tissue to cushion the fall. So usually na-absorb ng bone. So you have to make them understand as well. Okay? Medyo difficult lang for this 85-year-old. Pero yun lang. Secondary sila among all your problems. Congrats, Louise.
Thank you for the
Marge. Okay, if there are no more comments for Maureen, thank you, Maureen. Our next is finish na si Maureen. Ay, Rika, okay, tapa ikaw na. Showtime.
Good morning po. Naririnig na po ako, Doc.
Yeah, I can hear you. Can you put on your video so we can see?
Hello po.
Okay, thank you.
Baka lang po kasi maging slower po yung network. Kapag naglag po ako, off ko na lang po yung video ko, Doc. Okay lang po.
Okay.
Okay po. Thank you po. So, good morning, doctors. I am Neuro Clerk Adrian Ricabella, and today I will be presenting a case on thalamic hemorrhage with the title Can't Wake Up. So on the next slide is the outline for my discussion with the following objectives. At the end of the presentation, the audience will be able to know how to approach a patient with decreased sensorium. Specifically, they will be able to know the guidelines for the neurologic examination of a patient with decreased level of consciousness and to correlate the presenting signs and symptoms to the structures affected in thalamic intracerebral hemorrhage. So presenting to you the case of JA, a 71-year-old male, married, admitted on August 25, 2021 with a chief complaint of cannot be awakened from sleep. The source of the history and informant is his wife with 90% reliability. One day prior to admission, the patient was apparently well and had no other complaints, and then he then went to sleep. At the interim, the next morning, his wife was not able to arouse the patient from his sleep. And few hours prior to admission, the patient and his wife sought consult at the RHU, and his vital signs were as follows: BP of 200/120, heart rate of 60 beats per minute, respiratory rate of 24 cycles per minute, temperature of 37.6, pupils reactive to light with no nystagmus. He was given one tablet of captopril 25 milligrams sublingually and was arranged to be transferred at our institution and hence admitted. For the past medical history, the patient is a known case of hypertension maintained on amlodipine 10 milligrams daily but with poor compliance. Patient only takes the medication 2 to 3 days per week, and he was also unable to take amlodipine the day prior to admission. There was no history of diabetes or previous hospitalizations. Family history is positive for hypertension. Wife also seems to recall that there is also a positive family history for diabetes, and there is an unexplained sudden death of the patient's brother when he was 6 years old, wherein the wife does not know the reason on why this happened. For the patient's personal and social history, the patient was a driver, but had been staying at home recently doing just household chores. The patient has approximately at least 25 pack years of smoking history and is also an alcoholic beverage drinker who drinks about 5 to 6 times per week, consuming around 1/2 gin of bilog per session for approximately 50 years now. There was, however, no drinking episode the night prior to admission because of the liquor ban imposed during ECQ. Review of systems was tailored on the premise that the patient was apparently well and had no complaints the day prior to admission, but it should be noted that it is incomplete, this review of systems, because the patient was currently in an unconscious state upon admission. On the next slide, you can see the physical examination findings. The patient was unconscious. Hello? Rinig pa po ba ako, Doc? Okay, so for the physical examination, the patient is unconscious with the vital signs of 160/100 for BP, heart rate of 89 beats per minute, respiratory rate of 24 cycles per minute, temperature of 37.5, and oxygen saturation of 99% on room air. The patient weighs 90 kilograms and has a weight of 167 centimeters with a BMI computed at 32.3, obese on the Asia Pacific guidelines. For the thorax examination, there is symmetric chest wall expansion with clear breath sounds, a dynamic precordium, normal rate, regular rhythm, point of maximal impulse at the sixth intercostal space left with clavicular line with no murmurs noted. The extremities show full and equal pulses and no edema was noted. The neurological exam upon admission is as follows. Patient's GCS was 7, E2, B2, M3. The patient was only able to open his eyes and moan incomprehensively when a pressure to his navel was applied. His right extremities assumed a decerebrate posturing, and his left extremities assumed a decorticate posturing, also in response to the noxious breath. stimuli, giving him a score of 3 for his best motor response. NIHSS score was 99 because the patient was not alert, stuporous, and able to follow commands. Thus, he got a score of 2 on the level of alertness, LOC commands, and LOC questions. For the best gaze, the patient has a forced gaze looking down, not overcome by the oculocephalic maneuver. The oculocephalic maneuver is done by opening the patient's eyes and turning the head briskly from side to side. Normally, the eye should move in the opposite direction of the turn of the head, but the patient exhibited forced gaze palsy looking down and was scored 2 for the best gaze. For the visual, the patient scored a 2 since there was no response to the visual threat on the right eye. The patient exhibited a right central palsy where there is a clear-cut paralysis of the lower half of the right hemifacial area. To test for facial asymmetry in alert patients, we usually ask them to smile and we observe the asymmetry of the facial muscles. In an unconscious patient, however, we usually observe their face asymmetry when they grimace in response to pain. That is why the patient scored 2 on the facial paralysis. All of the limbs scored a 3 for the motor examination because all of the limbs fell when released in a position against gravity. That is why 5A, 5B, 6A, and 6B are all scored 3. For a limb ataxia is not present in a paralyzed patient, and thus the patient received no points for this. The sensory exam, the patient scored a 1 because he still was able to respond to a noxious stimuli by grimacing. But there is the corticate posturing on the left and the cerebrate posturing on the right. For the best language and dysarthria, patient scored 2 in both sections because the patient was stuporous and has unintelligible speech. The patient exhibits a decreased level of sensorium arousable only by painful stimulus. Cranial nerves 2 and 3 were intact due to the preservation of the pupillary light response on the right side, since the left assumed the corticate posturing faster than the right side of the body, assuming a decerebrate posturing. There is also more pronounced paresthesia on the right because of the same reason. With the findings on the history and physical exam, these are the silent features of the case. For the subjective, a 71-year-old male, known case of hypertension, non-compliant to medications, apparently well the night prior to admission, with inability to be awakened from the sleep on the day of admission. The objective salient features include the vital signs: BP of 160/100, heart rate of 89, respiratory rate of 24, temperature of 37.5, and O2 sat of 99, GCS 7, E2, V2, and 3. Decreased sensorium, preferential downward gaze, no response to visual threat on the right, right central facial palsy, quadriplegia, decorticate posturing on the left, decerebrate posturing on the right, and right hemiparesthesia. On the next slide, we will see the guidelines for the neurological examination in patients with altered level of consciousness by Safdie et al. Next slide, please. Naririnig, okay po. So, according to Safdie et al., these are the guidelines for the neurological examination in patients with altered level of consciousness. So, first, for the mental status, we need to identify the level of arousal. Is the patient spontaneously awake, or is he aroused by minimal verbal stimulation or with a noxious stimuli? Doc JM, pakibalik po dun sa table na ano. Okay, so I'm so sorry for the discrepancy on the audio and the video presentation. It seems that I hello po, Doc.
Hello.
Yes, Rika. Go ahead.
Hello. Hello. Okay, so team with the so to approach unconscious patients or patients with acute declining syndrome, for the cranial nerve, corneal and the gag reflex, we can drive for the vagus nerve. For the motor function, we can evaluate or assess if the patient has voluntary or purposeful movements, reflex withdrawal to pain, or if there is any spontaneous involuntary movements, or if there is any increased tone, muscle tone, in resistance to passive movements. Also, we can do the deep tender reflexes. We can measure them if there is hyperreflection or sensation in response to a noxious stimuli on the limbs. According to Singhal et al., the causes of acute decline in sensorium can be divided into the neurologic and the toxic metabolic causes. Metabolic and hypoxic encephalopathy as causes of the acute decline in sensorium in the patient are less likely due to the asymmetrical presentation of the neurologic diseases in the patient. Onset of deficits, trauma, tumors, and infections becomes less likely. Thus, we are possible causes of the acute decline in sensorium in this patient. For the next slide, we can see the possible localization of the lesion based on the patient's signs and symptoms. So vertical gaze palsy. For the vertical gaze palsy, the patient is looking down and the lesion can be traced to the mesencephalic diencephalic junction or the junction of the midbrain to the diencephalon containing the thalamus, the hypothalamus, and the epithalamus, which contains structures for vertical gaze and convergence. The paramedian thalamus contains descending inhibitory cortical pathways convergence. And these pathways extend to the contralateral vergence neurons in the midbrain, which then project to the ipsilateral oculomotor medial rectus subnuclei. Force, forced downward deviation in thalamic hemorrhage may reflect the number of structures crucial for normal vertical gaze. These structures include the interstitial nucleus of Cajal, the mesencephalic reticular formation, the posterior commissure, and the rostral interstitial nucleus of the medial longitudinal fasciculus. Damage to any of these structures may disturb the normal position of the eyes in the vertical plane and impair active vertical eye movements. So highlighted in red is the mesencephalic diencephalic junction, which may be the cause of the vertical gaze palsy with forced downward eye is the manifests as the absent response visual threat in the right. I think that the optic nerves 2 and 3 are intact because of the preserved pupillary light reflex, localizing then our absence of visual threat at the level of the thalamus or higher in the um, visual pathway. So with that, the absent response to visual threat in the right is localized, probably on the area highlighted with yellow. Next, we have the right central facial palsy. So the face actually can be divided into 4 quadrants, right upper, right lower, left upper, and left lower. The upper quadrants receive innervation from both from both the left and the right cortex. That is why in central facial palsy, there is preservation of the facial muscles on the upper half of the face due to this dual innervation from the left and right hemispheres. But the lower half of the face is innervated uh, only by the contralateral cerebral cortex. That is why when there is uh, lesion on the supranuclear facial nerve pathway, then there is no preservation of the contralateral lower facial muscle movement. So, yun po. So highlighted in blue, we have from the thalamus up to the um, cerebral cortex. Next, we have the left decorticate posturing. So in primates, the rubrospinal tract influences primitive grasp reflexes. The rubrospinal tract carries signals from the red nucleus to the spinal motor neurons. Primates are reliant on fine motor skills, and therefore the motor cortex via the corticospinal tract is more prominent in movement than phylogenetically lower regions. Extensive lesions involving the forebrain, diencephalon, or rostral midbrain are known to cause decorticate posturing. This includes the motor cortex, premotor cortex, corona radiata, internal capsule, and thalamus. The red nucleus via the rubrospinal tract causes a flexion, grasping type reflex of the upper limbs. With higher brain centers, such as the cerebral cortex, they inhibit this reflex flexion caused by the rubrospinal tract, such that with a lesion of the corticospinal tract, the red nucleus is disinhibited, and the flexion reflex of the upper limbs is unimpeded. The vestibulospinal tracts are also left disinhibited, and the extension of the lower limbs occur.
Hello po. So for right decerebrate posturing, the lesion can be localized at the level of the red on the next slide, you'll see my primary working impression. Ay, pakibalik po kuya. So to answer the questions, is there a lesion? Yes, there is a lesion because of the focal neurologic deficits. I levelized it
The upper motor neuron, lateralized it on the left with asymmetrical presentation, localized at the left thalamus and left midbrain, probably a vascular versus acute hydrocephalus lesion. So with this, my primary working impression is shown on the next slide to consider stroke, ischemic versus hemorrhagic, roll out acute hydrocephalus. So for the diagnostics needed in order to diagnose stroke, according to the Stroke Society of the Philippines, since our patient has an NIHSS score of 29, then he is classified to have a severe stroke. Shown on the figure on your right are the guidelines for severe stroke and the management priorities and subsequently the emergent diagnostics. So I ordered a plain head CT upon admission, and the results are shown on the next slide. In here, we can appreciate glaring is a hyperdensity on the region of the left thalamus with intraventricular extensions on the lateral ventricle, on the posterior horn of the lateral ventricle, and also into the fourth ventricle as shown on the cuts on the second row. So there is hyperdensity there in the fourth ventricle. Also of important note is the visualization of the temporal, the second to the third rows of the head. Cerebral hemorrhage volume using the modified Cotari method, A times B times C all over 2, with a slice thickness of 1 centimeter. And I computed an intracerebral hemorrhage volume of 23 ml. On the next slide, we can see on the next slide discussed is the intracerebral hemorrhage, which accounts for approximately 10% of all strokes, and about 35 to 45% of patients die within the first month. The most common causes of cerebral hemorrhage are hypertension, coagulopathy, sympathomimetic drugs, and cerebral amyloid angiopathy. Hypertensive cerebral hemorrhage usually results from spontaneous rupture of a small penetrating artery deep in the brain because they are the most prone to develop hypertension-induced vascular injury. Thus, the most common sites of hypertensive ICH are as follows: basal ganglia, especially the putamen, then the thalamus, followed by the cerebellum, and then the pons. ICH presents as the abrupt onset of a focal neurologic deficit, and seizures are uncommon. Although clinical symptoms may be maximal at onset, commonly the focal deficit worsens over the next 30 to 90 minutes and is associated with a diminishing level of consciousness, headache, and vomiting. Thalamic hemorrhages, on the other hand, produces contralateral is the pathophysiology of hydrocephalus due to intraventricular hemorrhage. So thalamic hemorrhage can extend into the ventricular system and thus causes different of a cascade of events that ultimately leads to hydrocephalus. So first, we can have CSF drainage pathway blockage due to the irritation of the ependymal cells. Next, we can have direct ependymal injury because of the blood effect to the ependymal cells in the ventricles. And also the degradation products such as the iron from the blood in the ventricles can have direct toxicity to the ependymal cells, leading to the destruction of cilia, obstructed CSF flow, and the destruction of the aquaporins, which facilitate the movement of the CSF inside the choroid, inside the subarachnoid granulations, and there is therefore build-up of CSF into the ventricular system, thus causing hydrocephalus, which is manifested by the visualization of the temporal horns of the lateral ventricles in the CT scan results of the patient. So with this, my final diagnosis is shown on the next slide. CVD bleed, left thalamus with intraventricular
Hello po. For the management, according to the Stroke Society of the Philippines, these are the recommended management principles for
So for confirmed hemorrhagic stroke on CT scan, we give supportive treatment by giving mannitol 20 kilograms from 0.5 to 1 kilogram body weight every 4 to 6 hours for 3 to 7 days. We give neuro protection and we give anticonvulsants for clinical seizures. And for proven subclinical or electrographic seizures, prophylactic anti-epileptic drugs are not generally recommended. We also do neurosurgery consult if the patient has not herniated yet, if there is lobar bleed, or if the bleed is located in the putamen, pallidum, or cerebellum, and the family is willing to accept consequences of irreversible coma or persistent vegetative state. The goal is to reduce mortality. ICP monitoring is also, if ICP monitoring is contemplated and salvage surgery is considered, we also refer to neurosurgery. So on the next slide is the ICH score, which predicts the 30-day mortality of patients with intracerebral hemorrhage. So we have the Glasgow Coma Scale, the age, the ICH volume, and the presence of intraventricular hemorrhage with location of the ICH as parameters. So my patient has a score of 2, which has a predicted 30-day mortality rate of 30 to 44%. After immediate attention to blood pressure and airway protection, focus can switch to the medical and surgical management for ICH. If the hematoma causes marked midline shift of structures with consequent obtundation, coma, or hydrocephalus, osmotic agents can be instituted and preparation for placement of ventriculostomy or parenchymal ICP monitor. So shown in the next slide are from hospital day 1 and on hospital day 2. So on the first hospital day, the patient was admitted. Diagnostics was requested, such as the CBG, plain head CT, serum electrolytes, BUN, CREA, albumin, 12-lead ECG, CBC, PPI-NRI, ATTT, FDS, and SARS-CoV RT-PCR. At the ER, the patient was given PNSS 1 liter for 12 hours and anacardioline drip. Citicoline 1 gram once a day was also given for neuroprotection. Lactulose 30 cc once a day on the hours of sleep was also ordered in order to decrease straining with the patient. IFC insertion was also done, and the vital signs and the neurovital signs to be monitored every 15 minutes for the first hour, and subsequently every 2 hours, and then every 4 hours. So on the second table on your right are the subjective and objective assessment of the patient on his second hospital day. So vital sign was 200 over 120 on the cardiopin breath. So the initial blood pressure upon admission or before the institution of captopril, the RHU was 220, 200 over 120. So bumaba na the patient's BP has decreased at 200 to 120. However, his mean arterial pressure was still at 146. That is why the cardiopin drip was still continued. The patient was febrile at 39 degrees Celsius. That's why paracetamol. Retrospect, I could have dealt with the hyperglycemia of the patient because his FDS was on 9.85 millimoles per liter. So it is high. So in retrospect, I should have ordered or insulin in order to counteract the hyperglycemic state of the patient. So also on this day, he was referred to neurosurgery for consult because there was pooling of secretions on the patient's oral cavity. He was intubated. And it was then during this time that his pupils became non-reactive to light. So the patient is now for possible decompression. That is why I consulted with the neurosurgery for possible decompression. So on the next slide are the orders for the hospital day 3. So at this point, the patient's blood pressure is at 180 over 100 on the cardipine 4 milligrams per hour. He's still febrile with urine output of 1080 ml and input of 3360. In here, we can appreciate the I'm sorry. Upon referral to the neurosurgery, the patient became a candidate for ventriculostomy in order to relieve the CSF buildup and the eventual hydrocephalus. Mannitol was ordered in order to prevent further cerebral edema and or in order to decrease the in order to diurese the excess fluid in the brain. So mannitol was ordered. Mannitol 20% was ordered at 450 ml every 6 hours, basing on the patient's ideal body weight calculated using Tannhauser's, basing on the patient's actual body weight of 90 kilograms. So next on my presentation, I have my journal reviews. So on the next slide is the sublingual versus oral captopril in hypertensive crisis. So the population in this study was patients with hypertensive urgency, wherein the patients in the intervention group was given captopril 25 milligrams sublingually, in contrast to the patients in the control group who received it orally. So the outcome of this study was that sublingual captopril was found to decrease BP more efficiently in the first 30 minutes, but this difference equalized at 60 minutes, meaning at 60 minutes, the decrease in BP was equally efficient in both the intervention and the control group. So the method for this study was a cross-sectional study. Next, mannitol in cerebral hemorrhage, a randomized controlled study. So the population in this was 128 CT scan proven supratentorial cerebral hemorrhage patients within 6 days of ictus. So mannitol 20%, 100 ml every 4 hours for 5 days, tapered in the next 2 days, was given in the intervention group. The primary endpoint was 1 month mortality and secondary endpoint was the functional disability at 3 months assessed by the Barthel Index score. The control group was given a sham infusion which contained no mannitol, and the outcome of this study was that the primary and secondary endpoints were not significantly different between the two groups, and low dose mannitol does not seem to be beneficial in patients with ICH. Lastly, we have the comparative study on the effect of citicoline on acute ischemic and hemorrhagic stroke. So the population in this study was 160 patients with hemorrhagic and ischemic stroke, given 1 gram citicoline injections daily for 10 days in addition to the standard therapy, in comparison to the control group which did not receive citicoline. Based on the findings of this study, the use of citicoline in acute stroke patients exerted no significant effect in the disease treatment in the short term. However, the long-term administration of this medication could result in significant impacts on the treatment of the patients, especially those with ischemic stroke and improvement of their efficacy. So this study was a randomized clinical trial. As a summary, we have first, uncontrolled hypertension causes cerebral hemorrhage in small vessels in the brain because they are most susceptible to hypertension-induced vascular injury. And such, the most common sites for hypertensive ICH are the basal ganglia, thalamus, cerebellum, and pons. And spontaneous intracerebral hemorrhage is a neurological emergency associated with high mortality and morbidity. Key management issues include prompt etiologic diagnosis, reversal of anticoagulation, consideration of surgical management, and the control of blood pressure. So here are my references, and that ends my presentation. And I apologize for the network interruptions. Thank you po.
Hello?
Hello, Doc.
Hello? Okay. Sige, Rika, wag ka na magbukas ng camera. We'll save on your bandwidth. So yung question so far, can you please correlate the patient's progressing neurologic exam findings with what was happening in her brain?
Yes, Doc.
So, sige. Hindi, before that pa. Nung meron kasi siyang neuro exam at the ER at saka neuro exam at the ICU at saka neuro exam after initial management and stabilization. Can you describe what's happening to her brain in each phase of those 3 time points?
Okay po, Doc. So initially po at the RHU, doon pa lang po, meron pa lang po sa patient was the thalamic hemorrhage. However, upon admission po at the ER, there was now intraventricular extensions of the thalamic lead. Hindi po, mali. At the onset po at the RHU, with the decreased sensorium of the patient, masasabi na po natin na meron ng intraventricular extensions po yung hemorrhage, causing hydrocephalus. That is why po, upon admission, dapat po at after na CT scan na yung patient, doon pa lang po nagbigay na ako ng mannitol in order to decrease po yung intracranial pressure po ng patient. However, it was an order lang po yung non-reactivity to light po yung pupils ng patient in the ICU to. So, possible po na nagkakaroon na po ng compression sa brainstem ng patient. That's meron din pong irregular yung respiratory patterns, tahimik, ganun po. Kaya dapat po sana yung mannitol, binigay ko na po as soon as na-confirm po through CT scan.
Okay, and then in your journals, there was one treatment option there, sublingual versus oral captopril. Will bad things happen if you very efficiently drop the BP?
So, yun po, Doc. Yes po, Doc. There are concerns regarding the very efficient BP lowering in the first 30 minutes because some say that it can cause cerebral ischemia. If, especially during that time, there is disruption of the cerebral autoregulation in blood flow. That is why if we drop or the BP drops very fast within 30 minutes, there is concern for cerebral hypoperfusion. But focused studies have not yet confirmed such any harm. I was not able to find journals recently, Doc, showing that there is a significant relationship between BP lowering and cerebral flow or oxygenation in the perihematomal region po in ICH patients. So there is concern of cerebral hypoperfusion, pero I was not able po to find literature that states that there a very steep drop in blood pressure in the first 30 minutes is actually harmful po.
Okay, so we accept that this journal was published, but we should use the information carefully in clinical practice. Okay. What dose is high dose mannitol in contrast to the low dose mannitol in the paper you found?
Okay, so in this paper po, they only used 100 ml for all the 128 CT scan proven patients with supratentorial ICH. So low dose mannitol in this situation is 100 ml po, regardless of the weight of the patient. So high dose mannitol can be 0.5 to 1.5 gram per kilogram po, Doc. So as was in the guidelines of the Stroke Society of the Philippines, this is what we use po. Yung mannitol regimen should be tailored on the patient's body weight po. So for my
So
patients, I use 1 gram per kilogram.
Okay. So if you will infuse low dose mannitol, it's like dripping mannitol by slow infusion. Its effect doesn't work because the primary and second outpoints were not significantly different if you give low dose mannitol to intracerebral hemorrhages. Okay. Are there other questions or inputs from our online audience?
Ako,
Sir?
can I have my input there?
Yes, sir.
Okay. So the thalamus is on both sides of the third ventricle. And here you see a large left thalamic bleed. So therefore, there's pressure on the third ventricle. And it causes obstruction of the flow from lateral ventricle to the fourth ventricle. Therefore, there's a hydrocephalus backlog going there. And can you see this pointer there or no? No? So on the right side, you see the large thalamic bleed which is very far from the bone, on the temporal bone. You see that's a lot of brain mantle that you have to go through if you want to evacuate this. So we don't want to evacuate that. And you'll see the atrium filled with the blood. And as pointed out by Rika, the temporal horn, and you see on the second row on the right side most film there, you can see the temporal horns on both sides. They are dilated, indicating there's a development of hydrocephalus there. Coupled with the decreased sensation of the patient, then this becomes an urgent case where, after doing CT scan and maybe checking the airway, then you have to refer this patient for decompression. So this was done, was referred, and the neurosurgeon did a right frontal ventriculostomy. So meaning they drilled a hole here and then pass a tube going to the right frontal horn to quickly drain the ventricle to reduce the intracranial pressure. And I was told when they hit the right frontal horn with the tube, the fluid literally shoot up, indicating a very high pressure. And this was drained into the closed system drainage in order to reduce infection or ventriculitis. I think this was done, and the patient started to get better because the pressure has been reduced. And so what to do with this tube in the head? You cannot leave that there for a long period because you risk infection. So I think this is the 10th or 12th day already. The neurosurgeon started to elevate the tubing, so that to see whether the patient can tolerate without the tube, and started to close the tube to see whether they can remove the tube. And for some reason, I think Dr. Manalo saw the patient last night, and he said that there's a down sunsetting of the eye or a vertical gaze palsy. So he opened the tubing so that CSF will flow again to reduce the pressure. So further evaluation of the patient will see whether he may need a permanent shunting. But with drainage further, we'll have to see whether the blood is resolved. Having RBC in there, it might clog a permanent shunt. It might clog the valve of the permanent shunt. So we'll have to see whether he'll need a permanent shunt, or we'll just take out the tubing. But it may be another 2 days before we risk infection, I think. So it'll be 14 days, 12 days, something like that. And so in the next 2 days, we'll assess whether we'll have to remove the tubing and observe the patient further, whether he deteriorates or not. But if he's doing fine, then he may be fine without any permanent shunt, permanent tube. So I think the case is nice because here you are in the ER, you're faced with a patient who was okay the day before, and then suddenly develops a decreased level of consciousness. And then the CT scan showed this thalamic bleed. So what do? Of course, Yes, decreased level of sensation, sensorium with the right hemiparesis and the thalamic bleed there and hydrocephalus. Put these things together, you need to drain, reduce the intracranial pressure. And the only way to do that is to release some CSF, by putting an external drain. So am I right, Dr. Manalo? Did you open the shunt last night?
I opened the shunt last night, and I am going to find out after this conference if there is still CSF transferring up the loop and into the bag. And I will update you after this conference.
Okay. Okay. Thank you.
Okay. If there are no more questions or comments,
Hi. Hello, Rika. Can we go through the journals you presented? Pero ang galing ng discussion mo, including the localization and, approach a patient with decrease in sensorium. So we have a comprehensive neuro exam, which ideally should be done face-to-face, but you know that it can be tailored depending on the circumstances, like teleconsult or examining patients who cannot articulate themselves, patients who are unconscious, and also babies. Babies, you cannot do the full neuro exam on them because they cannot follow commands. But for a patient with decrease in sensorium, yeah, we can be creative, in eliciting signs and symptoms of cranial nerves and brainstem and CNS dysfunction, by tailoring our neuro exam. So this is your first journal. The year is 2016. So if you're going to look at you compared captopril sublingual and captopril oral. And yes, sublingual captopril was found to decrease BP more efficiently in the first 30 minutes. So sublingual captopril really has a faster onset of action. But if you recall from yesterday's lecture presentation on acute ischemic stroke and TIA, it was not highlighted so much, but since you have access to the SSP guidelines, sublingual antihypertensive meds are discouraged, okay, because we want to avoid a precipitous drop in the BP. But yes, it can really lower your BP so much. But you have to take into account the circumstances also. Is this patient living far away, cannot seek any medical consult right away, then maybe yes, you can give it. But if the patient is in a nearby area or has access, then you advise them to go to the hospital right away, So panawid lang ito, but it's not. Captopril sublingual has actually already fallen out of favor with many neurologists, and I think with some IMs already, pati sa cardio, hindi na siya talaga first line. Okay? Next slide. Yung mannitol in ICH, the year is 2005, and there's low dose versus high dose. So yesterday from Francis's lecture, we remember that mannitol is given at 0.5 to 1.5 grams per kilogram body weight. So 100 ml every 4 hours for 5 days. This is, mannitol is computed per body weight. So 100 for, let's say, someone who is, 100 divided by 520 point. Someone who is 40 kilos, this dose of mannitol is not high dose for someone who's 40 kilos. For someone who is 50 and above, in body weight, then yes, this can be low dose. Okay, so you still compute it for, of course, for kids with lower body weight, mannitol 100 is not low dose. So low dose is relative compared to the patient's body weight. Kaya, yeah, it does not seem to be beneficial in patients with ICH. Kasi nga, low dose siya. And we compute mannitol based on the body weight. Right? Are these other journals? 2 lang. May isa ka pa? Comparative, yeah, this one. Citicoline on acute ischemic. So based on, so they compared as citicoline for hemorrhagic and ischemic strokes. Long-term, anong year to? 2018?
Yes po, Doc.
And hemorrhagic stroke. Okay, so actually, what was their endpoint? What did they measure in these patients?
Modified ranking scale
No
and
significant effect
Barthel
in the disease
index.
treatment or no significant impacts. What did they measure? MRS, cognition, was there
MRS
scale use?
index. They use po MRS and Barthel index po on the first 10th and 90th
Hello?
days post-intervention, Doc. Hello, Doc.
I don't think she's there. Sige. Sagutin mo na lang to, Rika, sa Viber group chat natin, ha? Yung itong pagdiskusyonan natin itong citicoline and acute ischemic stroke and MRS daw. MRS. But it's only being given for 10 days kasi. We don't really give citicoline for at saka Barthel index. So these are functional, no? Tests of patient's function, which can also be affected by the patient's support, no? Rehab. Kasi kahit mag-citicoline ka, kung wala ka namang rehab, nakaupo ka lang. So, yun. Would you know how the citicoline works? Sige. Kasi actually, citicoline, we don't give it for hemorrhagic strokes. We don't. But we give it for ischemic stroke. Pero hindi lang 10 days. We give it for longer. It's actually in the SSP guidelines. ICTUS trial. Okay? For citicoline in ischemic stroke. But for hemorrhagic stroke, there are no large-scale studies to support its use. And if you actually look at the mechanism of action of citicoline as a neurotropic, it also enhances blood flow. So you wouldn't want that in a hemorrhagic stroke, no, for the blood flow to be enhanced. Yeah. Okay. Sige, thank you very much. But that was a very comprehensive lecture. I especially enjoyed your discussion on neuroanatomy. Thanks, Rika.
Thank you po, Doc.
Okay, for our last presenter
Dr. Guillermo,
is...
can I be excused?
Yes, sir.
Can I be
Ay, sige, sir.
May i-consulta kasi. Thank you.
Okay lang, sir. Sige, sir po. Thank you. Ay, okay. Okay. Our last presenter can now share screen. Hi, how are you? Okay, showtime.
Good morning, doctors. This is clinical clerk Hera Marie Avon Bose, and welcome to my clinical case presentation. Next slide, please. At the end of this presentation, the participants will be able to first recognize the history and physical examination of a patient with septic cavernous sinus thrombosis. participants will be able to correlate the salient history and physical examination features and findings of ancillary procedures to diagnose a case of septic cavernous sinus thrombosis. And lastly, we'll be able to manage a case of septic cavernous sinus thrombosis. Next slide, please. Okay. You use. Okay. So this is my assessment for the patient on the first day. So this is a case of MQ, 50 years old female, who came in with a chief complaint of headache, which is described by the patient as parang nabibiyak nasa loob and parang umaalsa, and also with diplopia. For the history of present illness, there's a 3 days history of headache, 7 out of 10 in severity, which and aggravated by exertion. The patient took paracetamol and afforded relief. However, no consult was done. Also, there's 2 days history of diplopia with associated pain behind the eye. Also, no consult was done. And a few hours prior to admission, there's progression of the above symptoms. And then the patient consulted in the RHU. The patient was transferred in our institution, hence admission. For the ROS, we have weakness or fatigue, fever, dizziness, heavy sensation of the head, and linear vertigo. Next. For the past medical history, the patient has a history of diabetes mellitus and hypertension, and however, the patient denies any previous surgery. For the OBGYN history, the patient is already menopause. Last menstrual period was when she was 48 years old, and she is gravida 2 para 2002. For the family history, the patient has a family history of diabetes, mellitus type 2, and hypertension. For the personal social history, the patient is married. She stays at home and works as a house manager. She doesn't exercise. She has a mixed diet, but there's no food preferences. The patient is a non-smoker and a non-alcoholic beverage drinker. For the objective data, we have for the vital signs BP of 140 millimeters mercury, heart rate of 84 beats per minute, respiratory rate of 22 cycles per minute, and a temperature which is a febrile of 36.7 degrees Celsius. For general survey, GCS 15 E4V5M6, the patient is awake, alert, conversant, and not in cardiopulmonary distress. For the anthropometric data, we have a height of 1.52 meters, weight of 70 kilograms, and BMI of 30.3, which is obese under the Asia Pacific classification. Also, the patient had facial pain and erythema, eyelid swelling, anecteric sclerae, eye redness, eye discharge, diplopia, paralysis of the left eye ciliary muscles. The patient have a grape-like painful lesions on the bilateral ears, painful erythematous lesion on the nose, and patent nares. This history and PE was taken in the RHU setting with only the BHERT facilitating the patient. Hence, I was not able to complete the history and PE at this setting. Also, at this point, I was suspecting to something that needs the patient to not be further agitated and needs immediate hospital care. That is why I immediately asked the patient to be transferred in our institution. Next slide. Yeah. So for the at this point for the diagnostic catechism, so does the patient have a neurologic lesion? Yes, the patient have focal neurologic deficit with the diplopia, the vertigo, the facial pain, the conjunctival erythema, the eye discharge, and cyclopedia. Next question we have is, where is the lesion? So first, we levelize. I levelized the lesion to be central. At this point, I levelized the lesion to be central based on the multiple cranial nerve involvement and the bilaterality of the cranial nerve deficits. First, we lateralize. It is bilateral, and lastly, we need to localize. So I localized the lesion in the subarachnoid space because the headache of the patient is aggravated with exertion, which is a sign of increased ICP. And so last is what is the lesion? The lesion is vascular. Next. So my assessment is to consider CVD bleed probably secondary to subarachnoid hemorrhage. For the plan, the patient was admitted at medical ICU. She was for close monitoring of vital signs, neurovital signs, and GCS. The patient was put in complete bed rest with no bathroom privileges, 30 degrees head elevation, pneumatic compression stockings with a diet of low salt, low fat, low mechanical diet, fluids of PNSS. And for the diagnostics, I ordered CBC, sodium, potassium, FBS, HbA1c, lipid profile, PT, PTT, plain cranial CT, and CT angiography. For the treatment, I ordered nibodipine 60 milligrams tablet every 4 hours. This is for the neurological deficits due to vascular spasm. We have levetiracetam 500 milligrams tablet every 12 hours. This was given as a prophylactic anticonvulsant. We have tranexamic acid 500 milligrams IV every 8 hours. This is to prevent rebleeding. And then nicardipine drip, an antihypertensive to maintain the systolic blood pressure to less than 150 millimeters mercury. Paracetamol, the analgesic given for the headache. Omeprazole, anti-emesis to avoid straining. Omeprazole for the possible stress gastropathy, metoclopramide, anti-emesis to avoid straining, and lactulose as a stool softener to avoid straining. The patient was also for COVID RT-PCR. Next slide, please. Okay. The history on NPE was only completed when the patient was at the ER and when she was already admitted. So for the complete history NPE, we have MQ, 50 years old female, married, house manager, came in with a chief complaint of headache, described as parang nabibiyak na sa loob and parang umaalsa and diplopia. So 3 days prior to admission, the patient experienced headache, 7 out of 10 in severity, aggravated by exertion, took paracetamol and afforded relief. However, no consult was done. Progression 2 days prior to admission, there was progression of the headache, diplopia with associated pain behind the eye. No consult was done. And few hours prior to admission, there is progression of headache and diplopia. The patient consulted in the RHU. The patient was transferred in our institution, hence admission. Next. For the review of systems, we have weakness and fatigue, fever, headache, dizziness, heavy sensation of the head, linear vertigo, painful paranasal lesion, and we have intermittent claudication and varicose veins. Next. So for the past medical history, the patient has diabetes mellitus type 2. She was prescribed with metformin 500 milligrams 3 times a day. However, the patient is non-compliant. Hypertension, prescribed with losartan 50 milligrams 2 times a day. The patient is also non-compliant with this medication. The patient denies any previous surgery and cannot recall or her immunization history. Next. For the OBGYN history, menopause at 48 years old, G2P22002, family history, family history of diabetes mellitus and hypertension. And lastly, we have for the personal and social history, the patient is married, a house manager, doesn't exercise, eats mixed diet, no food preferences, non-smoker, non-alcoholic beverage drinker. Next slide, please. For the PE, for the general survey, the patient is awake, alert, conversant, not in cardiopulmonary distress, weak looking, obese at 30.3, BP of 140/80, heart rate of 84 beats per minute, respiratory rate of 22 cycles per minute, temperature of 36.7, O2 saturation of 100 at room temperature. For the HENT, for the head, there is facial pain, erythema, and swelling. For the eyes, we have anecteric sclerae, pink palpebral conjunctival erythema, eye discharge, diplopia with downward gaze on the right eye, cycloplegia on the left eye, and ophthalmoplegia on the left eye, and the right eye have full EOMs. For the ears, there's a grape-like painful lesion on bilateral, no discharge. For the nose, there's erythematous paranasal mass, and then patent nares. For the chest and lungs, symmetric chest expansion, clear breath sounds, no retractions. For the cardiovascular, we have a dynamic precordium, normal rate and regular rhythm, no murmur. For the abdomen is flabby, soft, and non-tender. For the extremities, full equal pulses, no edema. However, there are blackish patches on the legs. For the neuro exam, GCS of 15, E4, V5, M6, the patient dresses according to age, is oriented to 3 spheres. There is no dysmetria, no dysdiadochokinesia. However, there is ataxia. For the cranial nerves, for cranial nerve 3, there's cycloplegia on the left eye, paralysis on the left eye of the medial rectus, superior rectus, inferior rectus, and inferior oblique. For the cranial nerve 4, there's paralysis of the superior rectus on both eyes. On cranial nerve 5, there's facial pain. For the cranial nerve 6, there is paralysis of the lateral rectus on the left eye, and other cranial nerves are intact. For motor, there's 5/5 in all extremities, sensory 100% in all extremities, reflexes, the patient is hyperreflexive with deep tendon reflexes 3+. There's bilateral Babinski reflex, and the patient has positive Koenig sign and Budzinski sign. Next slide, please. So on the second day, second hospital day, so this is my assessment. The patient is irritable, still have headache. There is facing discomfort, and there is nape discomfort. For the objective data, the patient have paranasal redness and tenderness, empyematous rhinorrhea, cervical lymphadenopathies, clear breath sounds, normal rate, regular rhythm, no murmur, soft abdomen, full equal pulses. The left eye is frozen with painful face, no facial asymmetry. There is grossly intact hearing, good swallow, no lateral signs. However, there is neck rigidity. And then for the previously ordered diagnostics, we have sodium of 143.60 millimoles per liter, which is normal. Potassium of 5.07 millimoles per liter, also normal. For the CBC, next image, we have we can see in the CBC that there is leukocytosis with segmental predominance and thrombocytosis. For the cranial CT scan, next slide, next image. Okay, so for the cranial CT scan, in this slice, we can see hyperdensities in the anterior and the right and left periphery of the brainstem, as seen inside the red circle, and also in other slices, not focused in, not zoomed in, we can see sulcal effacement. Next image, please. For the CT angiography, the result, there's the parenchyma is normal, midline structures are in place, no cisternal effacement, no ventricle size and configuration, There's intact skull and calvaria. Orbital paranasal sinuses and mastoid air cells are normal. Intact circle of Willis. No aneurysm seen. However, there is distended cavernous sinus. So with this, okay, seen on these slides are the, sorry. Okay. So seen on these slides are the salient features from the history and P of the patient. For the subjective data, we have headache, diplopia, no hearing loss, linear vertigo, painful paranasal lesion, intermittent claudication, varicose veins, DM type 2, hypertension, non-compliance to medications such as exercise, non-smoker, and non-alcoholic beverage drinker. For the objective data, we have the patient is obese, BP at 140 over 80 millimeters mercury, heart rate of 84 beats per minute, respiratory rate of 22 cycles per minute, temperature of 36.7 degrees Celsius. The patient is afebrile. GCS 15, facial pain, erythema, and swelling, conjunctival erythema, eye discharge, diplopia with downward gaze on the right eye, cycloplegia on the left eye, ophthalmoplegia on the left eye, full EOMs on the right eye. There's a grape-like painful ear lesion on the bilateral ears, erythematous paranasal mass, and ataxia. Next. For the cranial nerves, we have cycloplegia on the left, paralysis of left middle rectus, superior rectus, inferior rectus, and inferior oblique. For the cranial nerve 3, for the cranial nerve 4, we have paralysis of the superior oblique bilateral eye. Cranial nerve 5, facial pain. Cranial nerve 6, paralysis of the lateral rectus on the left eye. Other cranial nerves are intact. Motor 5 over 5, sensory one-handed in all extremities, reflexes DTR, deep tendon reflexes 3 plus, Babinski reflex on bilateral, and meningeal signs such as positive Koenig sign and positive Brudzinski sign. Next. So for the diagnostic catechism, for the first question, does the patient have a neurologic sign? Yes, the patient have a neurologic sign because of the presence of focal neurologic deficit, the diplopia, facial pain, conjunctival erythema, eye discharge, and cycloplegia. Next, we have next question is where is the lesion? So we levelize central because of the hyperreflexia and the positive Babinski reflex. We lateralize, so bilateral. And then we localize at the cavernous sinus. Cavernous sinus lesions present with cranial nerves 3, 4, 5, 6, and 6 deficits, which is present in the patient. The affectation of the cranial nerves is because they either pass through or beside the cavernous sinus. And what is the lesion? Since the cavernous sinus is part of the cranial venous system, the lesion of the patient is vascular. So our primary working impression, is shifted to cavernous sinus thrombosis, septic versus hypercoagulable state. So for my plan for this assessment, so we have the patient is transferred to CCU because of the negative RT-PCR, still with close monitoring for vital signs, neurovital signs, and GCS, head elevation, pneumatic compression stockings, diet with low salt, low fat, PNSS for fluids, diagnostics ordered was PT, APTT, D-dimer, CT venography, and blood GSCS. For the treatment, mannitol was given. This is an osmotic diuretic, given for the increased ICP and the cerebral edema, and enoxaparin given for anticoagulation, and then the ceftriaxone, vancomycin, metronidazole was given as a broad spectrum antibiotic to cover possible biotic etiologies. So ceftriaxone will cover for the methicillin susceptible SRA use, also with other gram-positive bacteria and gram-negative bacteria, the vancomycin for gram-positive bacteria, and for the methicillin-resistant SRA use, and metronidazole for anaerobic bacteria and possible protozoa. Also, diazepam 5 milligrams IV every 4 hours was given for the patient's irritability. Next slide, please. So for the differential diagnosis, first we have cavernous sinus thrombosis secondary to hypercoagulable state. So I rule this in because of the headache of the patient, the cranial nerve deficits, the hyperreflexia, the Babinski reflex, the meningeal signs, the intermittent claudication, the varicose veins, the history of diabetes and hypertension, obesity, and the absence of fever. However, this diagnosis is unlikely because the patient is a non-smoker, which is a great risk factor, and the patient has facial infections. Next, we have cavernous sinus thrombosis secondary to infection. I ruled this in because of the patient's headache, cranial nerve deficits, hyperreflexia, the Babinski reflex, meningeal signs, facial infections, and diabetes mellitus type 2. Next slide. So this is my assessment for the third hospital day of the patient. So for the subjective data, we have decreased headache severity. For the objective data, we have BP of 130/80, heart rate of 90 beats per minute, respiratory rate of 20 cycles per minute, temperature which is 37.5. The patient is now febrile. GCS of E3V5M6. The dimer, from the previously requested laboratory studies, we have the dimer, which is 480.10 nanograms per ml, which is on the normal range. Prothrombin time of 11.2 seconds, which is also normal. So since the patient is now febrile, the D-dimer and the prothrombin time results are normal, we can now rule out hypercoagulable state as the cause of cavernous sinus thrombosis. So for my assessment, now we have septic cavernous sinus thrombosis. Wait lang. For the plan, still for close monitoring, head elevation, pneumatic compression stockings, diet of still low salt, low fat, fluids of PNSS, and then the blood GCS result was not yet released, so I ordered for it to get followed up. And the mannitol was shifted to 20%, 500 ml IV for 60 minutes, since 20% mannitol was the only available mannitol at that time. And then we have the enoxaparin was shifted to prophylactic dose, which is 40 milligrams IV once daily. Paracetamol 750 milligrams IV every 6 hours as needed for headache and fever, fever of temperature of more than or equal to 37.8 degrees Celsius. Still with ceftriaxone, vancomycin, and metronidazole. So but in retrospect, the enoxaparin should have been discontinued at this point, since its use in septic cavernous sinus thrombosis is still controversial. Also, its use in septic cavernous sinus thrombosis can actually facilitate further dissemination of the infection. And the use of pneumatic compression stockings as a DVT prophylactic should have also been discontinued, because it is not indicated in patients who can actually walk. So next slide. So now our final diagnosis is septic cavernous thrombosis. Next slide, please. Okay, so due to the rarity of occurrence, septic cavernous sinus thrombosis may be misdiagnosed or remain undiagnosed, which can result in treatment delay in this potentially life-threatening condition. So cavernous sinuses are the most commonly involved sinuses in septic CVT, and it usually follows the infection of paranasal sinuses, dental abscesses, otitis media, and orbital infections. Next, for the etiology of this disease, bacterial infections are by far the most common cause. However, viral, parasitic, and fungal etiologies have been well described. As seen in this image projected, we can see different species of bacteria, strains of kinds of viruses, also fungi, parasites, and also with Mycobacterium tuberculosis. So this Staphylococcus aureus is the most commonly identified organisms. For the pathophysiology, okay. For the pathophysiology, the cavernous sinuses are paired sinuses located in the base of skull, on the superolateral of the sphenoid air sinuses. These are separated from the sphenoid air sinuses by thin bone or sometimes only by soft tissue. The content within the cavernous, the structures within the cavernous sinus are are the oculomotor nerve, cochlear nerve. We have the ophthalmic division of the trigeminal nerve, the maxillary division of the trigeminal nerve. We have C for internal carotid artery, and A for abducens nerve. As seen in this photo are the locations of the said structures. And moving on, for the venous blood flow, so the cavernous sinuses receive most of the venous return from the face via the superior and inferior ophthalmic veins. It also drains the sphenoid and ethmoid sinuses via the emissary veins. The cavernous sinuses drain in the internal jugular veins to superior and inferior petrosal sinuses. The dural sinuses veins lack valves. This lack of valves make the blood flow pressure.
Radiant's middle tower is under attack.
Okay. To continue, so the dural sinuses and the cerebral veins lack valves. This lack of valves make the blood flow pressure dependent, and blood can flow in either direction depending on the pressure gradient. These anatomic peculiarities, as well as the extensive direct and indirect vascular connections of the centrally located cavernous sinuses, make them susceptible to infections involving the facial structures and adjacent paranasal sinuses. The cavernous sinuses are tuberculated and may act like sieves to entrap bacteria, emboli, or thrombi. Infection may trigger thrombosis directly by causing septic thrombosis, or indirectly by precipitating thrombosis in patients already at risk of thrombosis due to predisposing thrombophilia. The infection may spread within veins, which is called thrombophlebitis, or as septic emboli that get trapped within the trabeculations of the cavernous sinuses. Bacteria trapped in the deeper layers of the thrombus may be protected from antibiotic penetration and can become a continuous source of infection. Intracranial infections like meningitis, subjugal abscess, empyema, and empyema can be source of direct spread of microorganisms to other cerebral venous sinuses. Next, for the clinical manifestations, we have So for the clinical manifestations, so the illness is usually acute and the patients are usually very sick, toxic, and afebrile. The latent period between primary infection of face or nose and the development of septic cavernous sinus thrombosis is usually less than a week. So seen in this table are the common signs and symptoms for septic cavernous sinus thrombosis. So we have fever, headache, frontal and retroorbital pain, diplopia, ptosis, fructosis, chemosis, extraocular dysmotility due to deficits of cranial nerves 3, 4, and 6, hyperesthesia of the ophthalmic and maxillary divisions of the fifth cranial nerve, decreased corneal reflex, dilated tortuous and retinal veins, and papil edema. The eyelid swelling. Sorry, for the concept map. So first we have the facial and sinus infections. In our patient, we have paranasal lesion with empyematous discharge and grape-like ear lesions. Ear lesions. Also, we have facial erythema and swelling. And then, since the blood flow drains from the face and sinuses into the cavernous sinus, there will be septic cavernous thrombosis. So in our patient, this is seen as the presence of headache, diplopia, fever, ophthalmoplegia, cyclopedia, facial pain, conjunctival erythema, and eye discharge. Also, septic cavernous thrombosis can lead to complications such as meningitis.
Roshan has fallen to the Radiant.
Wait lang. There's still explanation for the concept map. So we have obstruction of the ophthalmic veins lead to chemosis, fructosis, and edema of the ipsilateral eyelids, forehead, and nose. The retinal veins become engorged, which may be followed by retinal hemorrhages and papil edema. Vision in the affected eye is lost by a retrobulbar optic neuropathy without visible alterations in fundus. We have the involvement of the third, fourth, and sixth in the ophthalmic and maxillary divisions of the fifth cranial nerves, which lie in the lateral wall of the cavernous sinus, leads to ptosis, varying degrees of ocular palsy, pain around the eye, and sensory loss over the maxilla and the forehead. And within a few days, spread through the circular sinus to the opposite cavernous sinus results in bilateral symptoms. The posterior part of the cavernous sinus may become infected via the superior and inferior petrosal veins with the occurrence of abducens and facial paralysis. Meningeal irritation is caused by increased ICP, cerebral edema, and or dissemination of the infection. Next, for the diagnosis of this of septic cavernous thrombosis, we have radiologic studies and we have laboratory studies. So first, for the radiologic studies, we have cranial CT with contrast. In here, we will be able to see filling defects in the cavernous sinus along with expansion in the dimensions or bulging of the lateral margins of the cavernous sinus. There will also be heterogeneous enhancement within the cavernous sinus with intensive enhancement of lateral wall, densification of retroorbital fat and exophthalmos, and cranial CT with contrast confirms the suspected location of underlying infection as well as integrity of the bony structures. Next, we have cranial MRI with contrast. This is only complementary to CT findings, and it adds additional information about soft tissue and vascular structures. Its greatest contribution in patients in patients with non-occlusive CT scans or if the involvement of the meninges and brain parenchyma is to be evaluated. Lastly, we have magnetic resonance venography, CT angiogram, venous space of cerebral angiography, which confirms CT scan and MRI findings. Next, for the laboratory studies, we have CBC, and there will be evidence of high neutrophil count and blood culture. This is to determine the causative organism. Blood culture is most open positive in approximately 70% of cases of septic cavernous thrombosis than cerebral fluid cultures, which is only positive in 20% of cases. For the management, first, we have antibiotic therapy. This is the day of treatment, this is given as intravenously. And we have two regimens. First, we have the ceftriaxone, vancomycin, and metronidazole. And next is the third generation cephalosporin, naftracin, and metronidazole. In our patient, I use the ceftriaxone, vancomycin, metronidazole to also cover the medicillin resistant SORE use. And then we have for the total duration of antibiotic therapy, this should depend on the clinical response and associated complications, but minimum of 3 to 4 weeks is required. And however, this may be continued until 6 weeks or until there is radiologic evidence for the resolution of thrombosis. Next, we have anticoagulation. This is a controversial management. The theoretical advantage of anticoagulation is the prevention of propagation of thrombus, inhibition of platelet function, and its anti-inflammatory effect. The potential risk is the intracranial and systemic hemorrhage. And also, there is an assumption that the thrombus confines the infection, hence it prevents the dissemination of infection. And anticoagulation therapy may result in further extension of the infectious process. There's a trend towards decreased morbidity when anticoagulation is used early along with antibiotics. However, there are no protocols that has been established for the use of anticoagulation in septic cavernous sinus thrombosis. Next, we have steroids, also a controversial management. So its role is not well established. It may help in decreasing the inflammation and swelling, but its use is not well supported by evidence. Lastly, we have surgery. Surgery for these patients is only limited for the drainage and debridement of the primary site of infection. Next. For the prognosis, despite all the advances in diagnosis and treatment, the mortality rate is still reported at around 30% with significant morbidity in the survivors. Local complications such as intracranial abscess as well as remote complications like septic emboli and pulmonary embolization may occur. The residual deficits in the survivors include partial or complete visual loss, cranial nerve abnormalities, pituitary dysfunction, seizures, hemiparesis, facial disfigurement, as well as personality changes. Full recovery is achieved in less than 50% of patients. Next, for the plan. So, for the plan for the patient, so still with close monitoring, head elevation, since the possible infection may actually move for either direction, since the cavernous sinuses on the venous system in the cranial venous system is valveless, so we need head elevation still, diet of low salt, low fat, fluids of PNSS. So the patient is requested for MRSA screening to determine the appropriate antibiotic that should be given to the patient, and then the patient needs to be referred to ENT service for the management of the primary site of infection, refer to IDS, refer to endo for the DM, and refer to cardio for the in the ROS we found out that the patient has orthopnea 2 kilos. Also, the enoxaparin should be continued. Paracetamol still for as needed for headache and fever, diazepam for irritability, and we still continue with the broad spectrum antibiotic because although the blood GSCS result came out for the primary for the initial growth of staph aureus, it is not yet sure if it is methicillin resistant or not. So we still continue with this regimen. So these are my references, and that ends my presentation. Thank you.
Okay. If you could have palpated the patient's ears, what do you think those grape-like things were below her ears.
Radiant's top tower has fallen.
At dito, tsaka dyan.
Radiant's top barracks has
Hmm.
fallen.
Ay, hi, are you there? Hi. Frances, ikaw yung nagsiscreen share, ano?
Yes po, Doc.
Hi. Hyra, are you there?
So Doc, nakamute pala ako.
Ay, nakamute ka. Okay, game. So, ano yung mga
Sorry, Doc.
nandito?
So Doc, for the question in the chat box. Sorry, Doc, ang mahina po kasi yung audio. So for the question po in the chat box. So grape-like, ang ang pagkakaintindi ko po dito, since grape-like sabi po is mukha siyang grape-like kasi mukha siyang alveoli. So madami. And it is painful daw po. So this is possible ano ba to? Masakit daw po siya.
Oo nga,
So this
dito.
probably is still also a needs of infection po.
Oo nga, ano?
No, Doc.
Anong tawag doon?
Doc, mahina yung, hindi ko po alam, mahina yung audio.
Okay.
Hello, Doc.
Pwede mong i-type doon sa chat box, sige. Kasi wala yung ito yung limitation, di ba? Kapag telemed, you'll rely on the description of the person on the other end of what they are. But if you could have seen this patient live and you palpated, there were lumps here which were soft to firm, round, ganito kalaki. Sunod-sunod dyan. Ang tawag doon. Hala, choppy. Teka, sige, sagutin ko muna si Dr. Marge. Hi, Hyra, can you see us in the chat box? So if you can see us in the chat box, just type your answer to number 1. If you could palpate this patient's ears, what do you think are those things here? Tama ka, infection-related siya.
Doc, wait. Doc, kung mapapalpate po tapos sunod-sunod na hindi lang siya mag-isa or possible din po siya mag-isa, possible po siguro na lymphadenopathy po ito, Doc.
Okay, yun yung hinahanap kong word na lumabas dito. Following the anatomy, tama lang ba na magka-lymphadenopathy dito?
Doc, sa pre-auricular area, pre-auricular, post-auricular po sa may angle po ng jaw, possible po.
Dahil?
May mga lymph nodes po, Doc.
So, yung veins galing sa cavernous sinus saan papunta?
Doc, ano po yun? So,
After the blood leaves the cavernous sinus, where does it go?
sa internal jugular vein po,
Okay.
Doc.
Tapos, meron bang tawag dito sa space na to?
Saan po, Doc?
This. This space.
Danger triangle, Doc.
Okay. So, kung merong cardiac box, Kapag binutas mo, malaking kaguluhan. Meron ding danger triangle yung face for this specific reason. Pwedeng gumapang yung mikrobyo, papasok, at may infection yun at magulo siya. Okay, what are these patients' risk factors for getting septic cavernous sinus thrombosis?
Risk factors po of the patient for to develop septic cavernous thrombosis po, Doc, is the paranasal mass, which is on the subsequent days po actually drained an impaiumatous fluid po.
Ano pa?
Hello, Doc?
Kasi lahat ba ng nagkakatagyawat sa ilong at risk na magka-septic cavernous sinus thrombosis?
Doc, high risk po siya kasi may diabetes po siya.
Okay, sige.
High
So
risk
what
din, actually, since kahit staph aureus po yung initial growth, high risk din po siya for fungal mucormycosis infection po. Since ito po yung pinaka-common for DM patient na nagkaka-septic cavernous sinus thrombosis po.
So are there other signs or symptoms or complaints in this patient which would tell you that her diabetes has been there for a long time?
Doc, yung blackish patches po sa paa.
Okay, ano pa?
Doc?
Ano pa? Ano pa? Why is this patient ataxic?
Hello, Doc?
Bakit ataxic ang patient na ito?
Doc, is probably secondary po sa peripheral neuropathy po niya. Also that one of the reason din po aside from the diplopia kaya siya may vertigo po.
Okay. So, but if you were to have seen this patient, what would you have wanted to check live so that you would be sure with yourself that this patient's ataxia was related to diabetes and not something central? Because this constellation of physical exam and neurological exam findings were relayed to you not as first person, meaning you weren't there, somebody did it to you, you gave instructions. So there could be information which was not transmitted correctly forward or was relayed back to you correctly. So looking back now that you've seen, you've now laid out everything. If you were the first responder or the actual person there, what would you have wanted to check again? Just so everything would tie up together nicely.
Doc, for labs po for to check FBS HbA1c po, which is actually po nabigay naman po yung result po, Doc, and they are high. CBG is also high po, Doc, 304.
Okay. So the patient had ataxia. And if a patient has ataxia, it's a system, it's a circuit that you will be able to do this properly if the whole circuit is correct. If you cannot, it means there's something wrong. For example, if you can do it with your eyes open, but cannot do it if your eyes are closed. It means your eyes are fine and you can see the target. But if you remove the visual cue and you depend entirely on the sensation of your fingers and your body, they cannot do this if the nerves don't work. So that's finger to nose for the hands. For the feet and the legs, there's Romberg test. But it's also not specific test in that if it is positive, somewhere between the soles of her feet all the way up to her vestibulospinal system and back, something there is wrong. So you at least know where to start looking, but it is not specific to the cerebellum, for example, or to the pons. It just means that the reflex circuit is broken. Next, if I were the one who saw this patient live, I would check again reflexes because for a patient with chronic diabetes who will have impaired small fiber function, they will not be able to feel their feet. If they cannot feel their feet, then they will be confused. If they close their eyes, where their feet are, they can become ataxic. Also, if you have poor sensory nerve function, then the circuit going up to your lumbar spine and back to make your deep tendon reflexes should be reduced. So if I were to go back to this patient, I would check again the reflexes. Uh, if there was indeed another central lesion, or it's a peripheral lesion, or a combination of both. Okay. There are comments in the chat box. Wait lang. In sinus thrombosis, plain sinus thrombosis. Wait lang. Wait lang. Wait lang. Hello? Okay, game. In plain sinus thrombosis, we give anticoagulants. But in septic cavernous sinus thrombosis, it's not routine. Because the reason for the thrombosis is not a procoagulant. It's not specifically a problem of the coagulation pathway. There's a germ there and it's inflamed. So you treat the germ and the inflammation and the thrombosis goes away. Yan, antibiotic pa rin ang treatment for specifically septic. So yes, you do a lumbar tap and look for germs and see if something grew. Okay? Are there any other questions from our online audience? Go.
Hello, Hyra. Yeah, very good. At least you considered the points we also raised in our Viber group. In the beginning, your diagnosis was a subarachnoid hemorrhage, right?
Yes po, Doc.
Hello? Are you there?
Yes po, Doc. Nakikinig niyo po ba ako, Doc?
Ako naka-mute. Naka-on yung mic ko.
Yes po, Doc. Ala.
Hello? Hello? Yeah. Hi.
Hello, Doc.
Okay. Okay. Hi, Ra. Hello. Sige. So, narinig niyo naman ako kanina pala. So, I'm glad that the points that we raised in our Viber group, your initial impression was a subarachnoid hemorrhage, right? And yeah, we see here your treatment regimen for subarachnoid hemorrhage. Because of the initial symptom, also the nuchal rigidity. But can this patient also present with nuchal rigidity? Yeah, well, he did. Pero paano mo siya explain in relation to your revised diagnosis na septic CST? Typing here. Alright. Okay. Sige, so this, yun nga, you don't have the advantage of seeing the patient, but we can actually change our diagnosis naman as more information comes along. Of course, as doctors, when you're already attending to a patient, you want this to, be more spontaneous, no? More, so there's nothing wrong with having a different admitting and a different final diagnosis. Pwede naman magbago. Of course, if you get it right the first time, just based on history and PE, very good. No, actually, sa OPD nga, hindi mo na kailangan ng masyadong maraming test. Pero kung especially in this case, it's a complicated case and there are also many controversies, no? Not in the patient per se, but in the treatment regimen, like steroids and enoxaparin, no? But this is also a CNS infection on top that's localized in the cavernous sinus. So actually, malaman siya in the DM pa. Malaman siya na case for discussion. But in the beginning, you only had the benefit of the history, and so okay lang naman yung una mong diagnosis, but it's good that later on, as you realize and as new information was coming on, you changed. And gano'n naman tayo, dapat na doctors, we should be flexible, no, to information. We should be open-minded. And actually this case, it's a multidisciplinary case. So we also hear from other services on how to diet. There'll be an ENT on board, pwedeng neurosurgeon on board, an IBS on board, an endo on board, your neuro on board. So maraming pwedeng pag-usapan, tapos multidisciplinary siya na case. So okay lang yun yung una mong diagnosis. Tapos nagbago ka, okay lang yun. So very good report. Yeah, very malaman. Marami kasi pwedeng pag-usapan sa pasyenteng ito. That's all. Thank you.
Okay. Yeah. Hello. Okay. We'd like to invite other inputs from our online audience. Okay, if there are no more inputs from our online audience or questions from the chat box, thank you to all our presenters for tying up your 2-week virtual relation with our culminating activity. Yes, it will not be at par with an actual live rotation where you could actually see the patients, but this is as close as we can get right now. So someday when the community quarantine status improves, we hope you'd make the most with all your live patient interactions. To everybody